Hello, 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 ladies and gentlemen, hello. So, for every lecture, for every class that I am teaching, there will be a PowerPoint presented to you. There will also be a PowerPoint with a voiceover. And when necessary, there will be something that I call the 10-minute lecture. And that is where, after class, I will just give you the highlights of the class and what was discussed and the things that you may need to focus on for the exam. So this is our first class, our first lab, and this is the assessment lab. So I am going to talk to you about the assessment of your patient and how to do a nursing interview, take a nursing health history. We're going to talk about that. And also, there will be 7 questions on exam number 1 from this PowerPoint. And in looking toward the future, there will be 4 questions on the cumulative final exam from this PowerPoint. So, moving forward. So, the key concepts for the assessment lab, the nursing process is the 5-step problems process that nurses will use to guide their professional actions. An easy way to remember the steps of the nursing process is through the use of the mnemonic ADPIE. So in ADPIE, ADPIE, so A is for assessment, and this involves gathering data about the patient and their health status. Diagnosis being D, diagnosis using critical thinking skills. The nurse will analyze the assessment data that we just gathered to identify patterns in the data and draw conclusions about the client's health status, including their strengths, their problems, and the factors that may be contributing to the problems. And then P, planning. Planning will encompass identifying goals and then outcomes, choosing interventions, and then creating that all-important nursing care plan. So implementation is the I. Implementation will involve performing or delegating planned interventions. This is the step in which we are going to carry out the care plan that we have already devised. And then E is evaluation. And then evaluation will occur as the last step of the process and will involve making judgments about the client's progress toward their desired health outcomes, the effectiveness of the nursing care plan, and the quality of nursing care in the healthcare setting. So one important aspect of the nursing process is to remember that even though there are steps, this is not a linear process. We are not going to go from step 1 to step 2. Sometimes we go to step 1 and then something will happen and we can go right to step 3, and then we have to come back and then we can evaluate what we did in step 3. So this is not a linear process, but that is only something that will come with experience. So let's talk about assessment. Assessment is the first step of the nursing process. So assessment is the systematic gathering. Please remember that term, systematic gathering, because this is the basis for everything that we do. So assessment is the systematic gathering of information related to the physiological, psychological, sociocultural, developmental, and spiritual status of an individual. The purpose of the assessment is to obtain data to allow the nurse to help the patient. Data must be accurate and complete because the remainder of the nursing process rests on this foundation, which is the assessment and then gathering data. So, for the assessment will provide textual information that will become a part of the patient database. It will supply the data necessary for the nursing diagnosis, not the medical diagnosis, that is up to doctor, but it will supply the data that is necessary for a nursing diagnosis. And the assessment will reveal information about motivation and resources that will help formulate outcomes. So, assessment will help guide the choice of the effective interventions and how to best implement them, because after we assess our patient, we can begin to plan, even if only with thought. We can begin to plan how to help our patient and what best way to do that. And then assessment will act as a guidepost for reassessment, because we are not just going to assess our patient one time and then one and done. That is not how it happens. We are going to assess, then we may have to create an intervention. We're going to implement the intervention. We're going to carry out that plan. And then we need to go back and we need to think about, was that plan effective? Did we hit our goal? Did it help the patient? And if not, then we need to reassess again and then come up with a new intervention possibly in order to help the patient. So assessment will act as a guidepost for reassessment in the evaluation step that may determine any change in the care plan. So there are lots of types of assessment data, many types. So assessment data can be categorized as either subjective or objective. These are the two main types, subjective or objective. And they are categorized according to their source. Subjective data is also called symptoms data. And this is data that the nurse receives by direct communication with the client or with the family. So subjective is what is spoken. So two S's, right? Subjective is what is spoken. This is what the client or the client's family is telling you. So subjective data will reveal the perspective of the person giving the data. So this is the patient's perception, the patient's family perception, and it will include their thoughts, their feelings, their beliefs, and sensations, how they are thinking, what they are feeling, and then what they want to speak, what they want to say. So subjective data can be used to clarify objective data. So, for example, how did you get this scar? Now, they can tell us how they got the scar. That would be subjective. The scar in and of itself is objective, because that's very easy to validate, right? Because we can see the scar. On the other side of subjective data is objective data. And this is also called signs data, or the object, an object that we can see. Objective data is gathered by the physical assessment. Again, our object, if you will, is going to be the client. It is going to be the patient. And we are going to perform an assessment on this object, if you will, right? So that is going to be my objective data, what I am going to see. It can also be gathered from lab studies, because that is very factual. My client can say to me, my cholesterol level is elevated, but then when I look at the lab study for the cholesterol level, it may well be within the norm. So there is a conflict there that is inconsistent data. So with this, the nurse might go back and probe a little more and ask the patient if they are in fact on a medication that may be lowering their cholesterol. So theoretically, they may actually have high cholesterol, but looking at things now objectively, they do not, because their cholesterol level is within the norm. So Objective data can be gathered by the physical assessment or from lab studies or from a diagnostic test. Objective data can be measured or observed by the nurse, right? It is what is seen, or other healthcare providers, for example, in vital signs or in urine output. If my patient is in the hospital, for example, and they say that they have been up and in the bathroom almost hourly, they're being annoyed because they're going to the bathroom too much. So what the nurse may do is she may say, okay, let's measure your urine every time you go. And here it is the patient's perception, that they may be going to the bathroom frequently. Whereas when we're actually measuring the urine, their urine output might be quite adequate, 100, 200, however hydrated they are. But they're actually going to the bathroom like every 3 or 4 hours. They're really not in and out of the bathroom. And then objective data may be used to validate. Validate means check or verify. Verify means confirm subjective data. For example, if a patient's report of dietary intake may be inaccurate, the patient's weight could be monitored. So my patient comes into the clinic and they say that they have been following their low sodium diet, they have been following their low fat diet, and they've been taking a 15-minute walk every day. But when I compare their weight to a previous weight, and they have not lost any weight, or they may have gained a pound or two, then theoretically we know this really can't be happening. They are really not following the diet or doing their 15 minutes of walking. So data can also be classified as either primary or secondary. Primary data is data that is either subjective or objective, that is obtained directly from the client, either through what the client says or what is observed by the nurse. So primary data is me looking at this patient, whether it is something that I am assessing or whether it is something that they are speaking. Subjective, objective, that is the primary data. Secondary data is obtained secondhand, for example, from the medical record or from a caregiver in the home or a family member in the home. So primary is going to be from my patient. Secondary is going to be pretty much from everywhere else. The patient's chart, their lab studies, a diagnostic study, or from a caregiver or a family member. So ladies and gentlemen, please listen up. This is our first listen up of this semester. Listen up, and then listen up one more time for me. On page 46, there is a table 3.1, examples of data, their types and sources. Ladies and gentlemen, you will know that table. You will take a look at that table because I do believe that there may be 2 questions that are coming from that table. So skills of the nursing assessment, and ladies and gentlemen, I am going to ask you to listen up one more time. Please know the information on this slide. Nurses will collect data through the skills of observation, physical examination, and interviewing. Observation will refer to the deliberate use of all of the senses to gather and interpret patient and environmental data. Observing systematically, again, there is that term, systematically, will help to not miss an assessment area. So, whether you use my systematic approach, whether you develop your own systematic approach on how to do a head-to-toe assessment, once you know what works for you, once you have a system that works for you, you will be able to realize fairly quickly if you have missed an area that you need to assess. So again, observing systematically will help to not miss an assessment area. So there is a mnemonic for systematic observation, and that is HELP, H-E-L-P, HELP. So HELP, the H, HELP. Observe for signs the patient may be in distress, such as pain, their breathing may be labored. Do they need any help? E is environment and equipment. That is the E. So you are going to look for safety hazards. We are going to look at the machines and their lines, whether it's an EKG, whether they are hooked up to a cardiac monitor. Do they have an IV? Do they have a Foley catheter? Do they have SCDs on? We are going to check that the equipment is working. Oxygen. The catheter is draining. The oxygen is in place. We are looking at equipment, and we are assessing the environment. L is for look. We are going to assess the patient, appearance, breathing, dressings, odors. We are now finally going to look and start the assessment for the patient and whatever your systematic approach may be. So once I walk in the room, I'm going to first look and see, does my patient need any help? Are they in pain? Is their breathing labored? Do they need anything immediately? Do they need any kind of help? After that, I am going to look at the environment. I'm going to start looking at those IV lines. Are they patent? Is the Foley catheter draining? Are there tubes? What is the equipment? Are they hooked up to the cardiac monitor, and is the monitor working? And so finally, L, I am now actually going to begin focusing on my patient to begin my assessment. And then finally, people. P is for people. Who are the other people in the room? Are they family members? Are they other caregivers? And what are they doing? And why are they there? Please know the information on this slide. So physical assessment will produce mostly objective data and will make use of the following techniques, such as inspection. Inspection is the visual examination. Palpation meaning touch. Percussion is when we tap a body surface. Direct auscultation, that is listening with the unaided ear, meaning if my patient is in respiratory distress, I may be able to hear those lung sounds simply by standing next to the patient who is in bed. I may just be able to stand next to the bed and hear their sounds. And then indirect auscultation, and this is when I will listen with my stethoscope. Interviewing is a purposeful, structured communication in which nurses will question the patient to gather subjective data for the nursing database. The admission interview is structured and it is broad. In an ongoing assessment, the interview may be informal, very brief, and more focused. So, types of assessment. Assessment can be broad and general, or it can be very specific. So very broad would be the head to toe, that would be the generalized assessment, and then specific would be a focused assessment. The type of assessment performed will depend on the client's status in the moment. In inpatient settings, an initial comprehensive assessment is done on admission. So a complete head to toe assessment is going to be done on admission. And then other more focused assessments can be done over time, over the period of my shift. Meaning that if my patient comes in with abdominal pain, I am going to assess my patient. I am going to do the head to toe assessment. And of course, that is also going to include, a focused assessment on their belly, a GI assessment. But throughout the rest of my shift or throughout the rest of my time that I am with this patient, with this client, I no longer need to do another head to toe assessment. When I come in to reassess my patient, whether it's after I performed an intervention, if they begin vomiting, if they have diarrhea, if they complain of pain and I've given a pain medication, I am going to reassess again, of course, because I spend all of my day reassessing my patients, but I am going to reassess, but it is going to be a focused assessment. I no longer need to do another head to toe. I've already done that at the very beginning of my shift. The rest of my time is going to be a focused assessment. So initial and ongoing assessments, ladies and gentlemen, listen up, and then listen up one more time for me, please. Assessments are said to be initial or ongoing, depending on the time they are performed. For example, one time on initial patient contact or at repeated intervals. So the American Nurses Association, otherwise known as the ANA, the scope of standards driven by the ANA will apply to professional nurses that identify assessment as a professional responsibility. So, ladies and gentlemen, please take note that assessment, especially the initial assessment, that first initial admission assessment must be performed by a registered nurse. That it has nothing to do with facility. It has nothing to do with where you work or how many nurses are on your shift or how many RNs are present. None of that matters. The American Nurses Association, in their scope of standards of practice, has stated that that initial admission assessment must be performed by an RN, by a registered nurse. Thereafter, repeated assessments, focused assessments can be done either by a registered nurse or it may also be done by an LPN if you are working with an LPN. A nurse's aide, of course, will not be assessing at all, but that initial assessment must be performed by a registered nurse. So initial versus ongoing assessment. So the initial assessment, ladies and gentlemen, please listen up, continue to listen up. The initial assessment is completed when the client first comes to the healthcare agency or admission to the floor. It is related to the client's reason for them seeking nursing or medical assistance. It will provide the guidance for the care, because this is where we find out what the problem is, where the problem is, and what we can do about it. And it will determine the need for further assessment. An ongoing assessment will be performed as needed at any time after the initial database is completed. Now, please remember that initial assessment needs to be performed by an RN, but a reassessment does not. The ongoing assessment will help identify new problems. So maybe I gave my patient something for pain, but the pain medication that I gave my patient is now making them nauseous. So developing a new problem. The ongoing assessment will follow up on previously identified problems, right? That's why I'm going back into the room to reassess. I'm following up. And the ongoing assessment, this data will reflect the ever-changing state of the client. So, for instance, vital signs. Maybe when my patient first got to the floor, maybe they have a history of hypertension, maybe they were nauseous at home, they didn't take their blood pressure medication. So I am now going to give them their blood pressure medication. And so now their blood pressure will come down to a more normal level. Or when my patient comes to the floor, or I see my patient for the first time, their pain may be controlled. Maybe they took something at home, maybe they were given some medication in the emergency room, and now they're up with me on the floor, and their blood pressure will be within the norm because they have no pain. Their pain is managed, their pain is controlled. But now that pain medication is wearing off, and so the pain is coming back, and now their blood pressure could be elevated. So, comprehensive assessments, also called patient database or the nursing database, and this will provide holistic information about the client's overall health status. So, to identify client problems and strengths, we will do this assessment. The assessment will enhance sensitivity to a patient's culture, their values, their beliefs, and their economic situation. And a comprehensive assessment will use the nursing skills of observation, physical assessment, and then interview. Focused assessments will be performed to obtain data about an actual, potential, or possible problem that has been identified or is suspected. A focused assessment will focus on a particular topic, a particular body part, or the functional ability rather than on overall health status. For example, focused assessments for pain or nutrition. A special needs assessment. A special needs assessment is a type of focused assessment that will provide an in-depth information about a particular area of client functioning. It may be performed anytime. Assessment cues suggest risk factors or problems for the patient. For example, a nutritional assessment is a special needs assessment, and that is done when warranted by the patient needs or their condition. So they may appear malnourished, or they may be newly diagnosed as a diabetic. So for this, we will need to do a nutritional assessment. Who does the grocery shopping? Do you eat a lot of processed foods? Who prepares the foods? Do you live alone? Do you cook for yourself, etc.? Pain assessment. Pain screening for all patients during initial and ongoing assessments is a special needs assessment. Cultural assessment is awareness of cultural influences that should guide your nursing care. There are some cultures where a female cannot care for a male patient, or a male nurse cannot take care of a female patient due to culture or religious reasons, unless another family member is in the room or if they're not comfortable. Foods, dietary issues lead to cultural issues, etc. Spiritual health assessment will provide insight into how a client's spirituality is affected by current life events and health status more than asking about a client's religious preference. So, asking them if they are a member of a particular parish, if they have a parish community that they're a part of, is there somebody that we can call for them? Psychosocial assessment will include data about the family, lifestyle, and usual coping patterns, understanding of the current illness, personality style, previous psychiatric disorders, recent stressors, major issues related to the illness, and then their mental status. And then a wellness assessment. And this will include data about spiritual health, social support, nutrition, their physical fitness, their health beliefs, and their lifestyle, as well as a life stress review. So, a family assessment will provide a better understanding of the client's family-related health values, beliefs, and their behaviors. A community assessment will provide information about community demographics, their health concerns, their environmental risks, community resources, norms and values, and points of referral. And then a functional ability assessment. This is a specific kind of special needs assessment. Health problems and normal aging changes will often bring a decline in functional status. Mobility, feeding, bathing, dressing, incontinence, and toileting can be impacted. So functional ability is especially important in discharge planning because future rehabilitation and palliative needs are derived from this functional ability assessment. So whether the nurse does it or whether the physical therapy department does it, someone needs to do this functional ability assessment. Can this patient take care of themselves at home? Can they bathe? Can they feed themselves? Can they prepare their food? What can they do independently? And then what do they need assistance with? And then, ladies and gentlemen, please listen up, and then listen up one more time for me. The Joint Commission back in 2020 requires an initial functional ability assessment based on the patient's condition. So, this functional ability assessment needs to be completed with the initial assessment and with the initial interview. And it is based on the patient's condition at that time. At that time. So, if your patient comes in with a fractured hip, they cannot walk independently, they cannot bathe independently, they cannot dress independently, they cannot prepare and get their food independently. They need assistance. And that's what the functional assessment is going to be based on. From the Joint Commission, they require the initial functional assessment to be based on the patient's condition at that time. Please take note. So now we've talked about assessment, and so now I want to talk about communication and how we can better communicate and the power of communicating with our patients. So, ladies and gentlemen, please listen up and listen up now. Taking a nursing health history. So, if you have an older man that is admitted with a fractured hip, the physician is going to be interested in the cause of the fracture, the extent of the injury, any pre-existing medical problems that would suggest that the client may be a poor surgical risk. And that is the physician's lane. That is the doctor's lane. That is not the nursing lane. Nursing is also going to ask about the cause of the injury. Nursing would also want to know what effect the injury has on the patient's ability to perform everyday activities. Oh my gosh, doesn't that sound like an initial functional assessment? And number 2, to identify support and strengths to begin planning for discharge and self-care. And then, ladies and gentlemen, the nursing health history will cover some of the same topics as the medical history, but the rationale for the questions is going to be different. The physician is asking because of his lane, of what he needs to do for his lane. He is going to ask questions that will guide him to think, is this patient a good surgical candidate? Will he do well in surgery? How much is he going to need after surgery to get back to his baseline? Nursing is going to be thinking about all of that and so much more. So please continue, ladies and gentlemen, please continue to listen up. Health history forms will vary according to the purpose. For example, inpatient, clinic, surgery, medical, emergency department, everybody is going to have a different form. Most will include questions about the following components. So even though the form may be different, ladies and gentlemen, what we are asking is all going to be the same. We are gathering the same information. We are gathering biographical data. The chief complaint, why is the patient seeking health care? History of the present illness, how long have they not been feeling well? When did the injury occur? The client's perception of health status, and then expectations for care. Is this something very simple? Yes, I know my hip is fractured. Doctor is going to fix it. I may have to go to rehab. After that, I'm going to go home, and then I'm sure eventually I'll be fine. Past health history, and this is sometimes called the medical history, the family health history, social history, medication history, whether they use any devices. Do you use CPAP at home? Do you have sleep apnea? Do you use oxygen at home? Are you insulin dependent? Do you have an insulin device? Complementary alternative modalities. Do you use hypnosis? Do you go and get a massage? Do you different Reiki, energy therapies? And then the review of the body systems and associated functional abilities. Ladies and gentlemen, please listen up and know the information on these slides. Ladies and gentlemen, please continue to listen up. Interviews may be directive or indirective. So a successful interview will include a combination of closed and open-ended questions. Closed questions can be answered with a yes or no or other short factual answers. They usually begin with who, what, when, where, and what. Do, did, does, and is, are, were. So, open-ended questions will specify a topic to be explored, but phrase it broadly to encourage the patient to elaborate. So such questions will obtain subjective data. So from the answers to the broad questions, it can be identified which topics to clarify or follow up with specific and closed questions. The nurse should, exhibit active learning behaviors by leaning toward the client, facing the client, exhibiting an open, relaxed posture without crossing the arms or the legs, and maintaining eye contact. So, closed questions, of course, are yes or no questions. Are you in pain? However, we can ask, how did you fall? How did you break your hip? This will lead to some short factual answers, but with that, we can continue to move on and gather more information. How, what, and when are acceptable lines of questioning. It is beneficial for the nurse to ascertain how a patient's issue has occurred. So it is okay to use those terms, how, what, when. So this is a comparison of directive and non-directive interviews. Directive interview is when the nurse controls the topics. It is mostly closed questions, yes, no, or very short answers. And we can obtain factually, easily categorized information, such as if we were dealing with an emergency situation. How did this happen? We want to get right to the point. We don't need a lot of, well, we were at a picnic, it was Aunt Sue's picnic, it was her birthday. We don't need all of that. I just need to know what happened to this person that brought them here. We'll talk about Aunt Sue later. Non-directive interview, that is when the patient controls the subject matter. It is mostly open-ended questions. How are you feeling today? What is going on at home? So what brings you in? It is more like a conversation. This promotes communication, it builds a rapport with the patient, and it will help the patient to express their feelings. So now that we have this data, there may be something that we need to validate. There may be some data that we need to validate. So the nurse will obtain an abnormal BP reading of 180/98, and the client will relate that they do not have high blood pressure. So we can validate this reading by checking the blood pressure on the patient's other arm. Is there a discrepancy? We can wait a few minutes and then take the blood pressure again in the same arm. So maybe if I sit and talk with the patient for a few minutes and get them a little comfortable, some patients will have white coat syndrome, whereas, they don't have high blood pressure except for when they come to the hospital or the doctors, then their blood pressure goes up. We can retake the BP using a different sphygmomanometer. We can compare the reading to a previous reading in the chart. Maybe the patient really does have high blood pressure. We can ask another nurse to double check. Remember, nursing is a team sport. So there have been many times where I've gone in, I've checked a blood pressure, I've listened to a heart rate, I've listened to lung sounds, and I know what I think I know, and that is I think I know what I'm hearing. But let me just get somebody's eyes, let me just get somebody else's ears to fact check me. So data should be validated under the following circumstances. Subjective and objective data do not agree, or they do not make sense together. For example, the patient relates that they do not have high blood pressure. However, the objective data is an elevated blood pressure. So my patient is saying to me, no, I don't have high blood pressure. Well, do you take do you take medication? Yes, I do. Well, no one takes, high blood pressure medicine just for the heck of it. Yes, you have high blood pressure. And going back and looking at previous entries in their previous blood pressures, yes, their blood pressure is elevated. The patient's statements differ at different times in the interview, meaning that their story is not consistent. For example, the patient relates that they follow a low cholesterol diet. However, the objective data, such as a lab study, is an elevated cholesterol level. So they tell me, yes, I've been following my low-fat diet. I've been very conscientious. I haven't stepped out. Well, yes, you have, because your cholesterol level is still elevated. So the data will fall far outside the normal range. For example, the patient shows no signs or symptoms of an infection. However, the objective data is an elevated temperature. So my patient is telling me that they feel fine. Nothing is going on. Maybe it's a urinary tract infection. Does it burn when you void? No. But yet, in looking at their urinalysis result, yes, they do have a urinary tract infection. Factors are present that will interfere with accurate measurement. For example, the patient is very large with large arms and an appropriately sized cuff is not available. So I can either obtain the patient's blood pressure when the appropriate cuff is available for an accurate reading. So I may simply document that I don't have the equipment to accurately take this patient's blood pressure. So ladies and gentlemen, listen up, and then listen up one more time as we talk about organizing data. Professional standards will require, again, that term systematic data collection. And this, again, is from the American Nurses Association, our National Council of State Board of Nursing, and the Joint Commission, right? They are all telling us, all of these big name people, the ANA, the State Board of Nursing, the Joint Commission, is telling me that I have to have a systematic, organized way for this data. This means when they want to come in and they want to look at my documentation has to be organized. Collect and record data in a predetermined category, not at random, meaning it is systematic. Whether it's head to toe, whether it goes by symptoms, but it is going to go systematically. Assessment forms use a body systems, otherwise known as the medical framework, that is useful for identifying medical problems. So some people like head to toe. Some people like to go by systems. This needs to be combined with other models to provide the holistic data needed to identify both nursing and medical problems. So what we are saying is that we don't care how you get it. We don't care what your system is, but it needs to be systematic, it needs to be categorized, it needs to be organized, and of course it needs to be validated. And then we can use Maslow's hierarchy of needs, as this model will group data according to human needs from most basic to highest. So this framework is useful in setting priorities in planning nursing care. Do you want to go to bed? I can finish this up in my room. You want to go to bed? So documenting data. Documentation of all assessment findings will benefit both the client and the nurse. We need to document everything. It will benefit clients by providing the basis for planning their effective nursing care, and it will protect the nurse by establishing the needed assessment was actually performed. So just remember, if you don't document it, it was not done. I can go in and I can medicate my patient. If I come out of the room, a family member is talking to me, and before I can go and document it, here comes Joint Commission, and they're looking and they're saying, oh, this patient's medication was due. Did you give it? Yes. Well, it's not documented. And they don't want to hear, well, I just didn't get to it yet. They don't want to hear that. What they're going to say is, if it's not documented, it was not done. So the nursing data is a permanent part of the client's record, which is a legal document. A malpractice suit may be filed years after a nurse cares for a client. So the assumption in malpractice cases is, if it isn't documented, it was not done. So there are guidelines for recording assessment data. Guidelines for recording assessment data include that we should document as soon as possible after you perform your assessment. You can record your data electronically, because that is how we do it now. Use proper spelling and grammar. Use acronyms sparingly. Use only agency-approved abbreviations. Do not make up your own. No one is going to know what you are saying. Write the patient's own words when possible in quotation marks. But please record only the most important patient words. Use concrete, specific information, and record cues, not inferences. Cues are what the patient says and what is observed. Inferences are judgments and interpretations about what the cues mean. So we just want you to be factual. You cannot infer your feelings, your thoughts, your opinion into the data. So we have some cues and some inferences for guidelines for recording assessment data. So cues are that the incision is red, it is draining pus, the edges are separated. Your inference is going to be that the incision is infected, and that very well may be true, but we cannot say that it is infected. I can't say that because I'm not a physician. Q would be the patient is tearful, states that father died of a heart attack, and they are now trembling. So the inference could be that the patient is anxious about a scheduled cardiac catheterization. Well, I can't document that because I don't know that. But what I do know is that they are tearful, that they are stating that their father passed away from a heart attack. They are now going for this heart catheterization, which is going to make them anxious, and they are trembling. These are all facts. I can validate each of those statements. And then a cue is when the patient states, I hate my mother, I wish I was dead. My inference would be that they're angry and suicidal. They may very well be angry, and obviously they are suicidal, but I can't say that. I can only simply document what they are saying. Tools for recording assessment data. Each organization will have its own form and formats for documenting initial and ongoing assessments. There could be a graphic flow sheet that will include vital signs such as their blood pressure, their pulse, respirations, and temperature, so that trends can be seen, right? Because we're nurses, we look for trends. Intake and output, otherwise known as I&O. We can record all types of oral intake, what they're drinking, their IV solutions, and their output. Urine, fluid from a drainage tube, whether they're vomiting. Nursing admission assessment, the initial assessment data collected and utilized to plan and develop appropriate individualized care for the patient. And then the nursing discharge summary. And this may be a part of the initial assessment form that is obtained on admission, and it is used for discharge planning. There is special purpose forms, and these are examples such as diabetic flow sheets for maybe their insulin or their blood sugars, and then the MAR, the medication administration times. And then electronic documentation. Initial data and ongoing assessment data are entered into a computer program for organization, right? It has to be organized, right? The Joint Commission says so, the ANA says so. It all needs to be organized, shared communication, and for easy retrieval. So I would like to thank you for your time and attention for this topic. I am going to cover the same topic, the same content will be presented in Assessment Lab. I just wanted you to have this so that you would be able to review it, as there are 7 questions on exam 1 from this content. Please reach out, ladies and gentlemen, with any questions, comments, or concerns. Thank you.